Hello, I'm David Amrall, Scientific Director for Autism BrainNet. I'm grateful for the opportunity to be with you today and tell you about Autism BrainNet. As a collaborative network of scientific institutions, Autism BrainNet facilitates the collection and distribution of brain tissue to advance autism research. Our goal is to promote innovative, high-quality research that can lead to a better understanding of the causes of autism and the development of new and effective treatments. I invite you to learn more by visiting our website at autismbrainnet.org. You can also sign up to receive our quarterly newsletter by visiting takesbrains.org. Thank you.
Hi, welcome everyone. I want to welcome you tonight to our PMSF Home Edition virtual conference. This is our third topic in the series, and we're very excited to bring this session to you tonight. For those of you who don't know me, my name is Diane Linehan, and I'm the Director of Operations at the Phelan-McDermid Syndrome Foundation, and I'm also the parent of a adult daughter who's diagnosed with Phelan-McDermid syndrome. And I will be your moderator tonight. First, I would like to thank our sponsors. We have two gold sponsors. We have Turner's Tribe, Robert and Eva Worthy and family. We have AMO Pharma as a silver sponsor, Autism BrainNet, Barrios and Associates, and Neuron Pharmaceuticals. We also had one silver sponsor who chose to remain anonymous. And to all these sponsors, I cannot express enough appreciation. Without their help, there's no way that we could do programs like this for our families. So I want to also let you know that you'll be able to go to the app and you can learn more about them. Feel free to read their bios on the app. And with that, I have a couple of housekeeping items. Speaking of the app, if you haven't downloaded the mobile app, I suggest that you do, and to really get the full experience of our sessions, because of course we can't be together in person, and maybe the app is the next best thing. It's really simple. You can go either to the Apple App Store, or you can go to Google Play, and you just put in PMSF, search on it, and look for the Home Edition virtual conference logo with a dark blue background. It's very simple. Download it, and then you'll be able to set up an account, and you'll be able to connect with other people who are participating in the session. It's really pretty neat the way you can, there are walls and you can post. So think of a wall like Facebook, and there's also chats, and that's like a text. So if, you can connect with particular people, or you can just post things in general. And there's a lot of information in there, but for nothing else, there's just some absolutely beautiful photos of our families from around the world and introductions. So once again, I just really encourage you to download. The next item is you'll have questions, I'm sure, as we go through the session. When you think of them, use the Q&A button at the bottom of the screen and type in your question, and we have help from Jackie Jacobs behind the scenes, and she's going to monitor the questions and compile them so we'll be able to answer as many as possible at the end of the session. So please feel free to use that option on your screen. So with that, I would like to introduce the session tonight. The title of the session is Psychiatric Illness and Regression in Teens and Adults with PMS. And the session will cover what we now know and some of what we don't know on this important topic. And it will pull on 4 different publications from the past year. And it is my great pleasure to introduce our speaker, Dr. Theresa Kohlenberg. And Dr. Kohlenberg graduated from Columbia University and Albert Einstein College of Medicine. She trained in pediatrics and developmental pediatrics. And then she trained as a child psychiatrist at Boston Children's Hospital. And for the past 20 years, she's worked in child psychiatry. You can read her full bio on the app and see some mention of the great body of her work. And Dr. Kohlenberg, or as we know and love her, is also a parent of a young adult daughter who's diagnosed with PMS. And so she, in her kind heart, has helped many of the families in our community. And so we are really delighted to have her speak to you tonight. And also, we will have 3 parent panelists who have agreed to share their personal story with you and their observations. And you won't see them right away. Tracy will come out first and she will do her presentation, but then you'll hear from Tracy Sutton, Sheri Hatch, and Melanie Duke. And with that, I'm going to turn the screen over to Dr. Kohlenberg, and then you'll see her presentation. She'll introduce the panelists, you'll hear them. Then Jackie Jacobs will come on and do the Q&A, and then I'll see you at the end. Thank you.
Thank you so much. I'm really honored and really grateful for all of the support from the foundation and from other parents that has made this work possible and made this conference possible under really difficult circumstances. And what I'm going to talk about tonight is the question of psychiatric illness and regression occurring in adolescence and adulthood in Phelan-McDermid, both what the literature shows and what families know, which is sometimes more. We're going to cover how this understanding emerged and what the research to date shows. We're going to talk some about what families have lived and learned. And we're going to talk about what we don't yet know and the questions that we face in the future. All of this stands on the work that's been done in the past 30 years by both caregivers, clinicians, and researchers on the support from the foundation, and most of all on the love and dedication of parents who participate in research and openly share their experience. So just to hark back, the very first description of Phelan-McDermid syndrome was published in 1992, and only in 2 years out came a description of a group of 7 more people. Both of these articles described young children with terminal deletions, and this was true because at that point, that's what could be identified was big deletions at the end of the chromosome. Early regression was recognized as part of the syndrome early on. And as the literature has grown, there have been a steady flow of reports that mention psychiatric illness and catatonia, and sometimes mentions schizophrenia in teens and adults with Phelan-McDermid, including some articles looking at treatment. At the same time as that's moved forward, a more affordable and new genetic testing has allowed the diagnosis in people with much smaller deletions or with the tiny mutations in SHANK3 that are called SHANK3 variants. And then in 2007, there was an article that was mainly focused on the association of SHANK3 mutations with autism, which included descriptions of regression in young adulthood. And some of them had symptoms suggestive of catatonia, although the diagnosis was not actually labeled in the article. So we came into this world in 2016 when our daughter was diagnosed with Phelan-McDermid, a SHANK3 variant, after 2 years of severe intermittent psychiatric illness of a variety of flavors. And her geneticist told us that not to worry because psychiatric illness was a really rare aspect of Phelan-McDermid. She had had first mania and then depression with some psychotic paranoid thinking Then she was well for a while. Then she had very severe OCD. Then she was well again. After her diagnosis, another 2 years later, she had a seizure and 2 bouts of catatonia. So she's really had almost every flavor of psychiatric illness that the field offers. When we first were diagnosed, we turned to the foundation for information and support, and then through the family community and the Facebook pages, we began to learn that what we were going through was not all that rare. And it became clear to me that the medical literature did not yet reflect the level of illness, the frequency of illness, or the types of illness that some of our families were seeing in our children. So in 2017, with support from the foundation, I began what turned into a more structured study of this, and finally got published in March of this year, just in time for the pandemic. So what do we know from the medical literature? There's a lot there, and I didn't think it made sense to try to talk about all of it, but there are 3 big articles that came out this year that tell us more systematically about psychiatric illness. And the first one I want to talk about is Willem Verhoeven's group, which looked at patients that they had followed over time. And it's, as you can see, it's called pharmacotherapy, but it's a bit more than that. And the big take-homes from that paper were that the problems that they saw were more consistent with something they called atypical bipolar disorder than schizophrenia. And I wanted to pull that out front because you see a lot of mention of schizophrenia in association with SHANK3 differences, but really that's not what we're seeing in our community. In their group of 24 people, 3/4 had terminal deletions and 1/4 had these little tiny spelling differences in SHANK3. They described 1/5 of them having recurring episodes of catatonia. 1/6 of them had had late regression, that is in their 30s, and all of those people had terminal deletions for what that small number tells us. And they focused a lot on how stabilization was achieved with supportive program environments and focus on reducing stress, along with the medications that they used. And I think that's an incredibly important point. The next big paper was Alex Collison and the other names here, including our very important geneticist, Catalina Bedenker. And what they did was to go through all of the publications that they could find with a tremendous number of different search strategies that mentioned any kind of behavioral or neurologic decompensation in adolescence or adulthood in Phelan-McDermid. And they found 56 case reports going back quite a long time. In parallel to what Verhoeven described, 3/4 of them had terminal deletions, 1/4 had the SHANK3 variants. And they said that the bipolar disorder, catatonia, psychosis, and loss of skills on average began at 20 years. That doesn't mean that everybody got it at 20. It means that if you took the people who got sick later and the people who got sick younger and you took an average, most of them was around 20, and almost all of them started having symptoms by age 26. Those case reports described symptoms consistent with catatonia in about 1/3, and it's interesting that that was more frequent in women than in men, and described loss of skills in over half of the people who had this kind of psychiatric illness. And it's important to remember that this was pulling together a wide range of different case reports that use different terms and focused on different elements. So it's kind of hard to add all the data up and be sure of what you're finding. Which brings us to the work that I had been doing and published with the help of the people whose names you see here. This study really started with conversations among families who contributed their questions and stories, and a lot of time the foundation provided connections and support And then when it came time to analyze what we had and to really think of how to put it in context of all the work that had been done before, it was enormously moved along by the contributions of the people whose names are here, including Brittany McClarney, who's the genetic counselor for the foundation. Families were invited to participate if the person with Phelan-McDermid in their family had experienced distinct psychiatric changes, such as the ones described here: mood episodes, psychosis, marked changes in sleep and energy, major loss of skills, new intense obsessive compulsive behaviors, or other neuropsychiatric difficulties. So we were not looking at long-standing behaviors that were part of who this person had been all along, waxing and waning in different ways, but we were really trying to look at distinct new onset trouble. And then informed consent was obtained, and the data that came out of the conversations was merged with the permission of families with the genetic and demographic data in the registry. And this allowed us to compare our sample with the broader registry sample, which was a good way to ask some questions. So in the end, who took part in these interviews were 36 guardians, 35 parents and one sibling, of 38 people with Phelan-McDermid. There were 2 sets of twins in the study. The people with Phelan-McDermid ranged in age from 13 to 50 at the time these interviews happened. And there was a female predominance, 31 females and 7 males. And we looked at what sort of genetic differences they had, because it would be really interesting if we could figure out who is at more risk for this kind of trouble. So we compared the study participants with the people in the registry who were in the same age range. We wanted to have a comparable group. And we discovered that people in our study group were less likely to have terminal deletions and more likely to have SHANK3 sequence variants than in the registry. There were still more terminal deletions than SHANK3 variants, but there was really quite a big difference. And the other thing was that the people with terminal deletions as a group had smaller terminal deletions than the registry sample as a whole. And we looked at the question of what was the developmental level of the people who became sick before they had psychiatric illness. And we found that they were more likely than the comparison group in the registry to have walked on their own, to have spoken in phrases or sentences, to have been independent with toileting, and to have been able to dress themselves. There were other things where they differed, but those were some big ones. We looked at what proportion already had what diagnoses, and one really striking finding is that only a quarter of the people in our study had been diagnosed with Phelan-McDermid before they developed psychiatric illness or regression. That is, it was their illness that had led to, in many cases, retesting with more modern testing and to recognition of the underlying problem. The number of people with autism diagnoses were really about the same between the people in the study and the people in the registry. The number went up after psychiatric illness hit, but it's really hard to tell whether that's because people changed or because they had much more systematic evaluations that led to the diagnosis. And as in the registry, about 40% had had a seizure without fever at some time in their life before the psychiatric illness hit. So at what age did psychiatric trouble start in our group? Most of them in puberty and adolescence between ages 10 and 18. Only a quarter started having trouble either early or later, sort of evenly split between ages 7 and 10 or after age 21. We thought about triggers, and of course, in medicine, we talk about the retrospectoscope. So all of us look back over things and wonder, you know, did this set it off or did that set it off? And you shouldn't attach too much to this. But caregivers did tend to identify stressors that were either psychosocial stressors, like a sibling leaving home to go to college, or graduating from school and starting in a day program, or losing a favorite caregiver. And there were also hormonal changes at puberty, infectious illnesses, and a few who were reported onset after having anesthesia for a variety of reasons. We absolutely cannot say this is proof of a cause because it's just an association, but we do know that stress hormones play a powerful role in the brain. So the association is, makes a certain amount of intuitive sense. And then what sort of psychiatric trouble did people have? Mood trouble. Most first episodes were either manic or depressed mood episodes. A few had this sort of mix of mood and anxiety symptoms, including abrupt onset of new intense obsessive compulsive issues or of separation anxiety. About half the group had psychotic symptoms such as hallucinations or delusions or really strange disorganized behavior. But these were only during mood episodes. It was very unusual for these to occur when somebody wasn't either manic or depressed. About a little more than a quarter were diagnosed with immune-mediated brain disorders such as PANDAS or Hashimoto's encephalopathy or autoimmune encephalitis. And most of them had many episodes of mood disturbance. So only 4 had just had one episode, and most of these were people who were interviewed within a year of the start of their difficulty. So it's quite possible that those people were going to go on and have further episodes. More than half had more than 5 distinct mood episodes with return to some form of calm or baseline in between. And over 40% had 10 or more distinct episodes. So this is really more the picture of something like bipolar disorder, which has this cyclic quality, than it is of a chronic brain disorder such as schizophrenia. Families reported some other issues, the new onset OCD, certainly, and intense tics, and intense new separation anxiety. And then there were pee-related behaviors. Families reported episodes of urinary retention, as well as compulsive, unproductive, sort of ritualized trips to the bathroom. And some families reported a group of symptoms that fit with a diagnosis of catatonia. So what is catatonia? It's a rare syndrome that can occur during psychiatric or medical illness. So it's not a standalone disorder. It is a thing that can happen when there's other forms of trouble. And it involves changes in motor patterns, in interaction and behavior, often in feeding and doing things for oneself. It can take the sort of movie version, which is freezing, stillness, and withdrawal, or it can take, in our kids apparently more often, a form that is agitated and restless. And it's marked by a bunch of unusual behaviors with German names that include holding odd, stiff postures, imitating speech or imitating motions other people do. It has a very severe form called malignant catatonia, which is even rarer than catatonia itself, which can be life-threatening and require ICU care. Catatonia is also seen in several other neurodevelopmental disorders, including a thing that affects some people with Down syndrome that's very much like the syndrome that I'm describing here tonight, a rapid onset psychiatric illness followed by loss of skills. That was at one point called Down syndrome disintegrative disorder. I think the name has moved on from there. There's a real concern that chronic catatonia could be confused with developmental regression. and that's something we can talk more about later. So how common was catatonia in our group? More than half reported symptoms that were consistent with a diagnosis of catatonia, but most of them were not diagnosed with catatonia, and most of the caregivers did not know that this was a possible diagnosis. And there was a very interesting pattern that catatonic symptoms were twice as likely to occur in people in our study who had SHANK3 variants as it was to occur in people in our study who had terminal deletions. Fascinating. So what about regression? Regression is a term that's used a lot in a lot of different ways. So we did note caregiver reports of early childhood regressions that are often seen in autism with a loss of previously acquired speech and social interest in imaginative play. But what we focused on in this study was late regressions that appeared after age 10. And we wanted to be really careful not to mix up loss of skills that was due to being sick with a psychiatric illness with permanent loss of skills. So we defined it that we only classified it as regression if the caregivers reported that the loss of skills lasted at least 6 months after any psychiatric symptoms had resolved. So how common was it? 2/3 reported significant loss of skills that began sometime in the 3 years after they started getting psychiatrically ill. And most of those people, in fact, started having regression within a year. The regression associated with psychiatric illness affected sort of, function across the board. It wasn't simply language and social relatedness like the early childhood regressions, but ability to walk and do things for oneself, cognitive functions. About half recovered a lot or completely. But the rest had little recovery, or in fact, a few had ongoing loss of skills in a sort of stepwise way. So how were these illnesses treated? With everything. Most people received multiple trials of psychiatric meds from a whole bunch of different groups for their symptoms. There was a pattern of antidepressants appearing to trigger first manic episodes when they were given for depression. And we know that antidepressants can trigger mania in anybody who's predisposed. Interestingly, people who were treated with those same meds for anxiety disorders did not show that pattern of developing mania. Antipsychotics were most helpful in lower doses and were and are part of many of our children's ongoing care, but they're known to trigger catatonia in anybody, and they may have been responsible for the emergence of catatonia in some. Benzodiazepines like Ativan and Valium and things like that are the mainstay of treatment for catatonia, and they're helpful in our patients as they are in the general public. A lot of people were on mood stabilizers, and those are drugs that are also used for seizure control. And some benefited from ECT or from immunomodulatory therapy, such as intravenous immunoglobulin. So what is ECT? ECT is also known as shock therapy, and it induces a brief controlled seizure. It's extremely effective for severe mood disorders and for catatonia. And I'm not sure really anybody knows exactly how it works, but it seems to kind of push some sort of reset button. It has a scary reputation because it was used in barbaric ways in history. But it is now a much safer and much gentler procedure. Anesthesia is used so that the person is not awake or aware during the seizure, and so that the body does not stiffen or shake. It can be complicated to use in people who are on anti-seizure medicine. And if somebody's an adult, in many states, it requires a court authorization, it isn't something a guardian can consent to without the court's involvement. And what is immunotherapy, and why are some doctors interested in it? Well, immunotherapy, like its name says, is anything that seems to modify or calm down the immune system, and it can involve steroids, immunosuppressing meds like Rituxan, intravenous immunoglobulin, or plasma exchange. Autoimmune disorders like lupus have long been known to have psychiatric aspects, and that's part of why there's such an interest in the interaction between the immune system and the mind. And psychiatry has been recognizing the role of the immune system in illnesses like PANS, or autoimmune encephalitis, which is people may be familiar with from the movie and the book it's based on called Brain on Fire. Immunotherapy has been tried in some of our patients, including my daughter. It's helpful for some, but not for all. So immunotherapy has been used in Down syndrome, and I'm not going to go through this paper, but in this similar pattern that seems to affect some people with Down syndrome, used and been effective for restoring them to peacefulness and previous abilities. And it's been used in Phelan-McDermid. This is the other paper that we put out this past year. And it's a description of 4 teenage girls with long-standing intellectual disability who developed severe neuropsychiatric illness in their teens that didn't seem to respond much at all to the usual psychiatric treatment. These were kids who were being seen by 4 different teams in 3 different medical centers who were not aware of each other. All of them were evaluated for possible immune causes and found to have possible triggers ranging from pretty certain triggers to maybe this is responsible triggers. All of them responded to immunomodulatory treatment. 2 very much improved, 2 only somewhat improved, and all have a chronic relapsing illness course where they require maintenance immunotherapy, and if it's stopped, they get really sick again. And they were all found to have SHANK3 mutations during their evaluations for psychiatric illness, and weren't known to have that before. So here are the biggest unanswered questions. We're almost done. How common is psychiatric illness and late regression in people with Phelan-McDermid? We really don't know. Is there a way to predict who will have these problems? Not yet. Is there a way to prevent these problems? Nothing that's been proven, some very good ideas. What are the best treatments for these problems? It's enormously interesting how different our individual children are from each other. A medication that was life-saving for one family may have been the most toxic thing that another family ever ran into. So that we're still just beginning to understand that. And then what supports can minimize deterioration once somebody is ill. And that's probably going to turn out to be, include some of the same things that have to do with prevention. There are questions for the scientific community. Why might it be true that those with SHANK3 mutations seem more vulnerable to psychiatric illness and catatonia and regression than those with terminal deletions? Is that some sort of artifact of this sample that won't turn out to be borne out by future research, or is it a real pattern? We don't know. And is there an immune or inflammatory component to these illnesses in general, or to regression itself? We don't really know what's happening when regression is happening. So these are big, meaty, and important to us as family questions. I imagine that pretty much everybody who sees this presentation will be asking themselves, will this happen to my child, unless it already has. And I want to say again, we do not yet know what proportion of people with Phelan-McDermid will experience these things. We think it's a minority. We think. It's really hard to live with uncertainty. Boy, do I know that. But it's worth knowing about these things as your child enters puberty, so that if they were to start to happen, you might recognize the pattern and know to reach out for help. So if your child starts to have distinct and intense episodes, such as the ones that are described here, I encourage you to reach out to the foundation. What can we do as parents? Well, the first thing is take part in research, including the natural history study. Research is what will help to answer some of these big questions and to give us treatments for our children. Keep good records, including short videos of your child at regular intervals doing a range of things that they can do in the way that they do them, so that if there is a change, you have something to compare. And we do have a project that's coming along that's a video toolkit. Be mindful of our children's sensitivity to social and medical stressors. Life has stress, and not all stressors trigger problems, but it's something to think about. Reach out if you feel that your child is getting into this kind of trouble. And make use of the PMS neuropsychiatric consultation group, also known by the acronym ECHO, which is what it sounds like, an expert consultation group available to provide support and information to your child's doctors, who may well be seeing their one in a lifetime one of these, and very much welcome some additional support. So we're going to move on now to what I call what families know, which is so much more and so much deeper in some ways than the published research. It means a great deal not to be alone with this, to learn from each other, and to have both practical and emotional support. And there are 3 families that have joined me today to share elements of what we've lived and learned, and to answer questions. And so I'm going to ask them now to pop up on the screen, and I'm going to ask that these slides go. It seems they have. Great. So everybody, you want to turn on your microphones, I think, or at least Tracy, because you're going to go first. So so here's the gang, wonderful group of brave, devoted, big-hearted women. And we'll start with Tracy Sutton.
Good evening, you guys. It's interesting to listen to Tracy go through all of these slides and think about what's gone on with my own children. I had to move around because my internet is giving me a hard time. I'm the mother of Brooke and Alex Sutton. They're 18-year-old identical twin girls. And we were not diagnosed until they were 13 years old. And but our history before that was Brooke and Alex just had your general delays, and we thought that was because they were twins, but continued to have some of these delays. When Brooke was in 3rd grade, all of a sudden we started out with seizures, and from the seizures, then we ended up going to a loss of skill. And originally we had been changing back and forth on seizure meds, and we had initially thought it was a reaction to the seizure meds. But as we were talking to our neurologist, she said, I think it's her brain. She said something's going on with her brain. So Brooke, who had been able to communicate fairly well, she was losing her ability to communicate. She was losing her ability to feed herself. And the way I saw it most was she was losing her ability to initiate. So Alex was maintaining her skills, but Brooke all of a sudden has this loss and this changes, which bringing in the girls together, the doctors were able to see the vast difference when we said, but she could do all the things that her sister could do. And now we're losing ground here. And our doctors were all kind of taken back because they weren't sure what was happening. And again, prior to her Phelan-McDermid diagnosis. So what they ended up doing was we had one neurologist who just kept saying she needs IVIG. And so our local neurologist finally said, let's just put her in the hospital. And for a week, we did IVIG in the hospital. And so she had her IVIG each week. So it's an infusion of immunoglobulin the thought is to kind of overhaul the immune system. And they were the only difference when we looked at all of their medical testing was Brooke's antibody levels for strep were over 1,500, and they were supposed to be below 250. So within about 2 weeks of doing the 5 days of IVIG, Brooke started regaining skills. She was able to start feeding herself again. Her toileting was coming back. And then she was also increased her communication. So with that being said, we went back. That was in November. We went in December. She did a booster dose. They were sending us to Mayo Clinic because no one knew what was happening. The doctor at Mayo Clinic, she was, and we had been told along the way, there will be additional, some new genetic testing that's coming out because previous to that, their genetic testing had just shown, we had done a microarray and there was nothing showing up in their genetic testing. Everything was there. So with that, the doctor, the neurologist at Mayo, she said, since she improved with IVIG, I just recommend she gets more of it. And when you see a neurological, immunological issue, and there's Brooke. So anyway, Brooke is really ready to see me. Hey, Brooke, can you go see Dad? Real life in action. Okay, so Brooke is communicating much better now than she had been. But she actually cried to go back to the hospital when it was time to get IVIG again. And she cried and said, I need to get that thing in my arm. And so for us, it was definitely something we saw improvement. Now, there are different times she does get it about every month now. And that improvement has waxed and waned. Between that time and now, she's had episodes where severe OCD. She's had episodes where we would say, the lights are on, but nobody's home. She would just be very kind of hollow and blank with her eyes. And she would spend tons of time moving her DVDs from one stack to another and could spend hours doing that. Right now, she's able to let me know when she's not happy about something. And with that, we just continue to do the IVIG. We haven't regained all the skills that we once had. Alex, on the other hand, has not had the same type of regression Brooke has had, but Alex also has very severe OCD. And she had started losing some of her communication. Her speech was becoming more difficult to understand. She also had been, starting to have more seizures within the last few years. And so we have tried IVIG with her, and while she has not regressed to the level Brooke had regressed, we did see some improvement with her. But it's hard to tell if that's continuing to work or not. So I just feel like it's a continual thing where we just have to take day by day and see what's going to come our way. So anyway, I'm going to pass it on to Sheri so she can share about her daughter.
Thank you, Tracy. Well, my daughter is Ellie, and she's 18 now. And at baseline, Ellie was a very happy, developmentally delayed child who was very verbal, really social. She was able to attend to her toileting needs independently. She could dress herself, although sometimes very creatively. She could read and write simple words. She was a really, really good sleeper. Ellie would sleep sometimes 10 hours a night. She would ask to go to sleep. She slept really, really well. She was really socially and motivated. She wanted to have like lunch with the principal, and she worked hard in school and she got awards, and she really enjoyed social activities. She would often ask to see her best friend. We have a large family, and she could attend her siblings' events, no problem. Sporting events, plays, anything that her siblings were involved in, she really enjoyed. And then around age 12, some mild psychiatric issues came into play. They were really mild, and they seemed cyclical. At 13, everything sort of fell apart. And first, over about a 2-week period, she lost bowel and bladder control. And then really kind of overnight, some really acute psychiatric issues just kind of hit really strong. All of a sudden, our happy child was crying inconsolably. We had a preferred event. We went to see Cinderella, and in the parking lot, she could not stop crying. It was so unusual. On that same day, I took her to a store afterwards to just kind of divert her, and she began throwing stuffed animals in the store. Again, really unusual for her. She started to not sleep well. She would sleep a little bit and wake up. There was screaming and crying, and she would wake up in the morning with a really unusual scream, and it could come back during the day. It could come back. Sometimes we would be driving on a familiar route to pick up one of her siblings from school, and she would just start screaming and biting the car seat, and it was just so unusual for her. One day she threw her favorite stuffed animal out of the car while we were driving. She just many, many unusual things. We went to a familiar restaurant that she liked, and she took her shoes off and began throwing them. So just really unique things. Also during this period, she had bouts of catatonia, aggression, extreme OCD on various different things she would be fixated on. And she also had urinary retention. After several months and many doctor's visits and a 9-day hospitalization, she was diagnosed with Hashimoto's encephalopathy, and then several months later with Phelan-McDermid syndrome. And Ellie also has Hashimoto's thyroiditis. So over the years, we've worked with many specialists, and each one has added something really beneficial. But for me, some of the things that I think have been most useful are, like Tracy mentioned, IVIG for Ellie has been really, really significant. It's somewhat of a game changer for her. I think it's just a reset where after the infusion, and I must say for Ellie, it's IVIG along with Solumedrol, the two together really have just made a very big difference for her. The other thing that's really important for Ellie is Ativan. I think Ativan has helped her tremendously with catatonia. I have seen there have been times where Ellie has been literally stuck in a pose and in a very unusual pose. And after I give her just a little bit of Ativan, she can resume her normal body posture. So those two things just really stand out. Many things have improved for Ellie, and many remain tough. She is no longer able to read and write. We try and try often, but she's no longer able to do that. Sadly, she's lost a lot of language. Her language comes and goes, and some days she speaks more than other days, but it's just different than it was. She can't have conversations back and forth, and if something hurts her, she's no longer able to say, and that's a really tough thing, that she can't tell us verbally what hurts her. We figure it out, but that's a really hard thing, that she can't say what it is that's bothering her. When I asked her siblings what they miss most about Ellie, because sometimes they'll say, we miss the old Ellie, they said that they miss interacting with her and having a conversation where she responds back to them. And they really miss her sense of humor, because she still has a good sense of humor. It's just that before she could joke back and forth differently than she can now. But on the positive side, she's not doing that awful scream anymore. She screams now, but it's more of an excitement scream, and it's just a much easier thing to tolerate. She's not crying inconsolably anymore. She enjoys her favorite toys again. She definitely, likes having them near her. Her sleep, especially recently, has gotten much better. She's able to use the toilet with assistance. She cannot do it independently, and she's not always consistent, and she still has frequent accidents, but she is able to sit on the toilet and use it. While her language has dramatically decreased, she can still say a lot of words. They're still in there. And she can randomly sing along to songs that she knows. And she actually still asks for her best friend. She can assist dressing herself, and she can put some things on independently. And I just want to mention Ellie's 2 favorite phrases that we hear now and then are, "You can do it," because we say that a lot in our house. And then occasionally she'll just look at me and say, "You're not the boss of me." So actually those are really great things that I welcome. I also think that I found that Ellie flares, and sometimes her symptoms are exaggerated when she's in pain. It's sometimes hard to figure out what is causing her pain. Often for Ellie, it's GI. It can also be GYN. But I've really seen where when she's in pain, the catatonia comes back, the loss of skills, the irritability, just things really change when she's in a lot of pain. And it's just something I've really noticed. I've also noticed for Ellie, constipation's a big thing. And when she's uncomfortable with constipation, it's the same cycle again, loss of sleep, and she really struggles. So we're really trying to work on that too. To wrap up, I just want to say that I think we all know what it's like having a loved one who has a rare illness, and the journey can be really tough and complicated and confusing and overwhelming and exhausting. And also, I've just found it to also be a journey filled with kindness and connection and inspiration and hope. And for me, when I think about it, it's just really a journey of gratitude. And there's just so many people I'm grateful for, our family and our friends and our awesome nurses and doctors, and just the incredible genetic counselors and therapists, and our PMS family and the PMS Foundation. And I'm really, really grateful for our kids, all of our kids, because I think they're just amazing teachers for all of us. And I'm really grateful. And then just last thing, my takeaway is just that teamwork makes the dream work. And I'm just grateful. So thank you. And on to Melanie.
Sorry, you may hear Chelsea in the background for a minute. She's getting ready to go. So I have Chelsea, who is now 31 and was diagnosed about 3 years ago, about 28 actually. So developmentally, she actually did well developmentally. The only concern we had was about 2. She didn't really lose speech, but she wasn't gaining any. So that began our referrals for speech therapy, occupational therapy, and a diagnosis of developmental delay, which kind of hung on for a long time. Years of speech therapy, she went to regular school. She was in a regular classroom until middle school. And, did well, had friendships. Middle school is when the academic stuff kind of, separated, and we decided to move her into like a life skills type classroom. But otherwise, Chelsea was very social. She played soccer, she played baseball, she learned to swim. She did, all of those things with minimal supervision. She could shave her own legs, wash her hair, all of those things. So we moved in 2002, and we prepped Chelsea for like 6 months about that. She was very excited. She was fine with it. In that summer, about 6 months after we moved, she developed pneumonia, but was not diagnosed for about 2 weeks. And after that treatment, after the antibiotics, after all of that, she just became a totally I would say, withdrawn girl. She went from very social, talkative, to not wanting to play, not wanting to eat, not wanting to talk to anyone, not wanting to go outside, nothing. So that went on for a couple of weeks. We took her to a neurodevelopmental pediatrician. They said depression. They started her on antidepressants because she had also lost a lot of weight, and that induced mania. So I'm a nurse, and I was like, this kid is bipolar. So that started our journey. We didn't have a PMS diagnosis at that point, and we started the treatment for bipolar disorder, started with antipsychotics. To make a long story short, they didn't work. They made things worse. Chelsea became confused. She had a lot of OCD about the bathroom. She was crying about things, not sleeping well, pacing the halls in the middle of the night, not knowing why she was up, just a lot of things. So that started our journey in trying to treat the bipolar disorder, which was not effective. And in the middle of all of that, Chelsea became unable to speak, unable to feed herself, unable to move, unable to dress. She had catatonia, but it was not diagnosed, and I didn't even realize that because it wasn't on my radar for her to have that for any reason. So it was about 18 months. We stopped all meds. She couldn't eat, drink, feed herself, nothing. No one knew what was wrong with her. We had lots of suggestions, but no actual diagnosis. So about 2 weeks, I'd say about 18 months and 2 weeks of no meds. Within a couple weeks, she was manic, full-blown manic again. So we started treatments again. They were ineffective. We ended up in a hospital 5 hours from our house. And it took 3 hospital admissions there for them to diagnose Chelsea with catatonia. So once that diagnosis was made, they tried medications. They were not effective, and they suggested ECT for us. So we did that. She did 17 treatments, went home, and did really well with medications and some adjustments for 4 years. And then she got sick again at age 20 and ended up in and out of the psychiatric hospital for 18 months. Resumed ECT. And so we are now 10 years, almost 11 actually, past that date. We got Chelsea's PMS diagnosis. Sorry, someone's horn's going off in our neighborhood. We got Chelsea's PMS diagnosis actually through a research study in 2017, because our neurologists and all our doctors kept saying, something's missing, something's missing, something's missing. And like Tracy, Chelsea had genetic testing at the age of 14 that showed nothing as well. So part of the research study was genetic testing that we did. They found her diagnosis, PMS, and told us to get it officially done by a geneticist, which we did. Like 3 months later, we got the official diagnosis. Also, Chelsea was diagnosed with epilepsy, I forgot to say, around the age of 21, like in this whole second cycle. But for her, all of her relapses have been illness related. We also did IVIG for 5 times and saw benefit, but we had to stop for other reasons. So currently Chelsea gets ECT once a week, and she's been on this schedule for 2 years now that she's once a week, but she has been consecutively getting ECT for the last 11 years, since the age of 20, because medications alone have not worked for her, and catatonia is the biggest issue for her. She kind of has up and downs, like Tracy and Sheri have said, and Tazy as well. Yesterday was a fantastic day for her. Today, we're seeing a lot of repetition, a lot of repeating. She'll whisper, like just different things. Yesterday, she was out riding her bike just like every other kid in the neighborhood. So I feel fortunate that we got the diagnosis, because it's connected me to this whole other family, all of you as well, but also it's made sense somewhere, because, you know, we also got a lot of, there's nothing wrong with your kid, you're babying her, like you need to push her. We moved for treatment for Chelsea and got a lot of like, Why are you doing that? There has to be something here, kind of thing. So Chelsea now, in the last, I would say 2 years, possibly 3, but she definitely has lost skills, whether they're ECT related, whether it's seizure related, whether it's medication related, whether it's PMS, we don't know. So that's kind of where we are right now. We are in the NIH study for the adults as well. So I think that there may be some callback on that, but I'm just hoping that together we can all figure out something to help our kids, so much better. So I appreciate being invited too, and that's all I have, guys.
Thank you so much. Thank you, all three. And I think we're ready now for questions. So all three could unmute. Panelists.
Hi, everyone. Thank you, Tazy, Tracy, Sheri, Melanie, all of you so much for your presentations and sharing all of your experiences. We have a couple of really good questions that came in, so I'm just going to kick us off. First question, do we have any information on how, why, when regression is caused by anesthesia, and what precautions can parents take to prevent this?
I'll take that one. No, we don't. If it's known, I don't know it, and I can take that to the echo consultation group. I think it's rare enough that it certainly isn't a contraindication to having anesthesia if somebody really needs a procedure. But it is one of the things that we've seen, and certainly if there's a way to avoid medications in the antipsychotic group as part of the anesthesia cocktail, that is probably something worth thinking about.
And let's see, how do caregivers or researchers distinguish between mania and depressive episodes, particularly for PMS individuals who are nonverbal or minimally verbal?
I'll start that one and you guys can chime in. The hallmark of mania that I think is useful for our kids is profoundly decreased need for sleep, which is not the same as trouble falling asleep or staying asleep because you're constipated or you've got a toothache or your family just moved. It's a revved up state in which people do not need sleep the way they usually do. And so that's a big difference. And then mania is usually either an elevated, excited, busy state or an irritable state, but not a draggy, sad, withdrawn state unless there's catatonia. So those are some big qualitative differences. Some of the people we know about have had tremendous weight loss during manic episodes, not necessarily because they're eating less and not even clearly because they're moving more, though it may be that they're burning calories because they're up and on the go. So the weight loss can be seen with depression as well, and that's hard to tell. But mania is a giddy kind of, in young kids, that my favorite story about mania is the 6-year-old who went in all seriousness to tell the principal how they were running the school wrong. And of course, with nonverbal kids, you're not going to get those behaviors, but you get a sort of new pushiness, like a kid who's generally been gentle will push past you, react really strongly to any kind of limits or expectations. Did anybody else want to say anything about that?
Go ahead, Melanie.
I will. I'll just say again, I'm a nurse. So when Chelsea had her first manic episode, it was, first of many, but it was clear mania. But also when she was in the hospital and manic, she was reciting verses from the Bible. And Chelsea could read. She can't now. She could then. but she couldn't read the Bible, and she was citing verses from the Bible. So I know that she's verbal, and you were saying nonverbal, but she also, as Tazy said, was like happy as can be and as productive as could be, like drawing stuff that we'd never seen her do before. I mean, it was crazy. So the school was like, she's doing great, and we're like, oh God, we're in trouble. So that was just one thing. And for the catatonia difference, for me, again, I didn't realize, because Chelsea had hypermotoric catatonia, so it looks like mania. But the difference when she had the hypermotoric catatonia versus her mania is she would just take like books, like Tracy said with the girls. She would take books and move them from one side of the room to the other and pile them back up. She would open and close all the doors, or she would move papers from one side of the room to the other. So there was no purpose in that, where when she was manic, she was like doing things we never even saw before.
Yep.
I was going to say, I think for Brooke's mania, and there's sometimes we have to stop and try to figure out, we're seeing that with Alex sometimes too, where they just can't stop. They just keep going and going and going, like the Energizer Bunny. And they can't lay down to sleep. They can't, Brooke will start opening up all of her DVDs, and she'll take her DVDs out and she'll stack all the DVDs and put all the cases to the side. I would say the difference from her, like, we didn't know about the catatonic, the active catatonia, until we actually had visited with Melanie. I didn't even know that was a thing. But I know, looking back, there are times when Brooke has been in phases where she's moving things, but like she's not connected with us. Like when we try to talk to her or try to interact with her, she doesn't look like she's there. When she's manic, she's just in hyperspeed, but she can still connect with us. And I would say for us personally, I think that's kind of the difference that I've seen with Brooke.
Great. So this is a question really to all of you. How many of you with your kids have tried any antipsychotics, Risperdal, Abilify, and did it help, not help? What were your experiences?
I think we all have. Let's just go around.
I was going to say, Brooke, we ended up with a lot of weight gain with her originally, and we didn't see as much benefit. But we have had a couple of instances where the doctor has just said, give her X amount to basically almost just knock her out because she couldn't stop. And they're like, that's what we would probably do at the hospital. That would have been with risperidone. Whenever she was given Haldol, when we were in, she was actually being put in the hospital to do IVIG because she had hit a level where, they basically had to block the hospital room door because she was ready just to run down the hall, screaming, yelling, and the ER doc gave her Haldol, which for her, she ended up basically catatonic after a dose of Haldol. And so our neurologist at the time just told us to stay away from the antipsychotics for Brooke in those situations. Because once the Haldol wore off, she was able to come back around, but it just put her in slow motion and she was not able to interact. So we've had some different responses, and there have just been times where she's either been so agitated or aggressive towards Alex that we have just had to go ahead and do a larger dose of risperidone just to basically knock her out and try to reset her system, is what it feels like, so that she might be able to feel better or get some rest or kind of get things reorganized so that it's easier for her to manage.
So I'll jump in here. Yes, we've tried every antipsychotic seriously on the market. And Chelsea takes Seroquel now, which is her lifesaver, and the ECT. But I feel like looking back that things got worse with the antipsychotics because for Chelsea, the catatonia was not treated and or diagnosed. So people were reluctant to use Ativan, give her benzodiazepines, teeny tiny doses. And once that catatonia was diagnosed and became part of the treatment protocol, I think that made a huge difference for us. We also had 1 dose of Haldol that caused neuroleptic malignant syndrome, but it was also because Chelsea was 12 days with no sleep. So you're much more, receptive to having terrible side effects when you have a lot of other things going on. But yeah, that's our experience. And Chelsea's on a high dose of Seroquel. She's on a high dose of Ativan. She has epilepsy, so she's on Lamictal, and she also gets ECT. So as Tazy said in the slide presentation, that is one heck of a balancing act. And to me, it's still bizarre how we're treating in certain ways, but right now it's the best that we have. And we've had questions about ongoing ECT repeatedly, and the doctors talk to us all the time, but we don't have another treatment. And this allows her to be home with us and functioning better than when she has catatonia. And so for us, this is kind of where we're sticking because there aren't other options right now.
For us as well, risperidone just really wasn't a match for Ellie. It just made her more checked out and vacant in a way, I would say. It wasn't a match. Also for Ellie, Seroquel was not a match. For her, she would have these enormous bladder accidents, enormous, where it just floods of urine would just pour all over. But yeah, those two just have not been a match for her.
And I can say from the study that there is no one medicine in that class that works better for our kids than the others. We went through 4 of them before we found one that in low dosage is really helpful. But the other 3 were really pretty nightmarish. And that seems to be, when I talk with families, now talked with about, I think 70 families who have some form of this now. And all that I can say is it's inconsistent who responds to what.
All right, we have a lot of really good questions coming in, so we're going to try and get to as many as we can. Is schizophrenia common in PMS, and how might that be related to regression?
No, it's not.
Okay, that was an easy one.
Yep.
Does anyone have any experiences of catatonia characterized by psychomotor agitation versus withdrawal or posturing?
I think 3 of us. Yeah, it's what's called hypermotoric or agitated catatonia seems to be a more common variant for our kids, though there's certainly people who've had the classic kind of frozen catatonia, and I've seen both in my child, but the hypermotoric catatonia is so rare in general that many psychiatrists have truthfully never heard of it, let alone seen it. And it's hard to distinguish from mania.
Yeah, and actually, Chelsea's first episode that was 18 months was the typical, what you think of catatonia, the stuporous catatonia. She couldn't walk, talk, feed herself, make any movements, get up and down, anything. But that was the only time, knock on wood if there's any, that she's had that. All of her episodes since then have been the hypermotoric. And yeah, it can wear you down pretty fast. But it also wears them down because Chelsea can drop 10 pounds in a couple days when she's has the hypermotoric catatonia, and she's very thin now. So, I mean, that's a lot.
Yep.
Is the positive correlation between psychiatric illnesses and small deletions or SHANK3 mutations at all due to the fact that in patients with large deletions, the assessment of psychiatric issues is more problematic?
It's such a.
I know that's a mouthful, Daisy. Let me know if you want me to repeat.
No, it's a question that we ask ourselves in the field, and I don't think we know the answer. It's certainly harder to assess mood or internal experience when somebody doesn't have language and relatedness. But then there are things like sleep and eating and purposeless, restless behavior, which if they are new to the patient are pretty strong indicators. But I'd say that because so many of our patients, our kids, don't sleep at baseline and roam and jump at baseline. And we're not talking about something that's been part of a kid all their life. We're talking about these very distinct changes.
Is ECT also complicated if an anticonvulsant is being used as a mood stabilizer rather than to treat epilepsy?
Mel, do you want to take that one?
So Chelsea has had ECT without a mood stabilizer. When she was 15 and had the ECT, she did not have a mood stabilizer on board. Her ECT was fine. We have several struggles now because she does have epilepsy. She takes Lamictal for her epilepsy, but she also needs ECT for her catatonia and her bipolar. So for us, the longer you get ECT, the less effective it is. And so you maybe need to use higher doses of ECT to produce a seizure. And that's where we are with Chelsea. Now, again, Chelsea's had ECT ongoing for 11 years, which they don't have anyone at Western Psych like her. So this is just a learning curve for us. But it is harder. But the question was, if you're giving it for a mood disorder, typically when you have ECT, a patient comes off all medications first, and they just do the ECT. And that was one case for us. The last 11 years, that is not the case. Chelsea takes all of her medication while she's getting ECT. And that is the challenge for us, is keeping her seizure meds at a dose that she doesn't seize, but low enough so that she can have a seizure induced for ECT. And that's where we struggle right now. So her epilepsy really should be treated with a higher dose of her Lamictal, but if it is, we won't get adequate ECT therapy.
And this will be a quick one. I think Tracy mentioned this. Someone asked what IVIG is. If you can just explain that real quick.
I think Tracy did before, right?
It's basically an infusion of antibodies that is made up of over 1,000 people's donations, basically conglomerated into one, and then over several hours they get this infusion. And the thought is that it kind of overhauls the immune system so that it works properly, is my take. Tazy, you may want to add on to that.
Well, there's two doses. A low dose is used for people who don't make their own antibodies well, to help them keep from getting infections. And that maybe includes some of our kids. And my own daughter has common variable immunodeficiency, and if it was bad enough, they would treat it with IVIG. But at high doses, IVIG is, they say immunoregulatory, which I think really is a bit of hand waving, because we're not entirely sure how it does what it does, just like we're not entirely sure how ECT does what it does. Yeah. But it's thought, one of the thoughts is that if you have an autoimmune problem, so some antibody you're making to some bug you met happens to be an antibody that's kind of the same shape as a piece of your own brain. And so your own antibodies are binding to and doing bad things to your own brain tissue, that by flooding with antibodies, you're actually sort of displacing, driving off the autoimmune ones. So I'm not enough of an immunologist to say more than that.
And I think doctors actually that we've talked to, kind of like, we don't really understand exactly what it does, but we've seen improvement for some of our patients with it. And I know for one of our doctors, they said, for Brooke, it was the best response that they had seen using IVIG, but it was a game changer for her. And as I can't put a direct correlation on it, but it's been interesting, is Brooke used to chew all the time. And like the chewing has stopped for her over the past couple of years. So I don't know if that's an age thing. I don't know if it's getting regular treatment, or, she just grew out of it. I don't know, but I found it very odd considering the number of things that she has chewed through the years.
So I'm aware that there's probably a whole slew of interesting questions backed up. Jackie, is that true?
There are a handful, yes.
Okay, so let's all of us discipline ourselves to be brief so we can address as many questions as possible.
Okay, so the next one, has anyone tried TMS for symptoms, which my Googling tells me is transcranial magnetic stimulation, but any of you please correct me if my Googling was off.
I'll take your Googling is not off. We've actually addressed that on multiple occasions for Chelsea because where we go, they do TMS. At this point, insurance will not pay for it because it is not a covered option. The other issue is that when you're using TMS, you are targeting a specific area of the brain to treat depression, which is what it's approved for currently. So you're mapping the brain and you're targeting a particular area to put those rays to, basically. And what we keep talking about with Chelsea is that where would we do TMS? Like what area of the brain would we target? Because she has epilepsy and because she sometimes has depression, she has mania. Would we make things worse? Would we make them better? There's no research. And so we would be like the first case. And again, trying to get insurance to cover would be difficult because we continually talk about, can we add in TMS for her to replace ECT or to decrease it? But we're stuck there.
Great, thank you. In hyperactive catatonia, are high doses of benzos needed? And if there are no responses to benzos, does this rule out that it is a more hyperactive catatonia?
So great question. I don't know that the doses are higher for hyperactive or hypermotoric than they are for stuporous. I don't know if they are, but I do know that sometimes you need really big doses of benzodiazepines to get on top of catatonia. So up to 24 milligrams a day is the protocol. And then if that doesn't work, the next step is ECT.
Great. And bipolar disorder, how is that diagnosed in people with PMS, particularly those who are not verbal or have limited communication skills?
If you have a clear manic episode, and there are criteria for the diagnosis of all these things in people who are of different levels of intellectual function, there's an adapted diagnostic manual for people of different intellectual levels. So if you feel that you can diagnose a manic episode or a pattern of cyclic mood disorder that includes depression and less classical mania, you can make that diagnosis. Could talk more offline.
Okay. And there may have been a typo. I'm hoping that this is correct, but the person who asked the question, feel free to chat in if this is not what you intended to ask. Has anyone had any experience with pseudobulbar effect and flare-ups where there's a loss of mobility?
I can, as far as the pseudobulbar effect, at one point in time with Brooke constantly crying, and there did not seem to be a particular reason why she was crying, and just had gone through one of these phases, and our neurologist had mentioned that. He said it basically, he coined it as pseudobulbar effect, and we didn't get treated specifically for that, but he just said, you know, she's got a very dysregulated brain right now because we couldn't find any rhyme or reason. So with that, we've had it discussed during some of these phases. What was the second part of that question? Sorry.
It was, no, that's okay. Yeah, I lost the question now.
Loss of mobility.
Loss of mobility, that's right.
Was that in relation to the pseudobulbar effect?
I'm not sure. It's not clear from the question, but they go together, so I assume, yeah.
Yeah, I don't have anything to add to that one.
Yeah, I was going to say some of the things that we would see with Brooke is more of, she could still do some of the things, but she couldn't initiate. So she would, like, as far as like eating and things like that, she would hold things in her hand, but never motorically get it up to her mouth unless I would go ahead and feed her, and then she would go ahead and eat. But it was like losing that ability to initiate to do any of those things. And the other thing is, sometimes when we start to see those phases, we'll see the left arm start to pull up.
Oh, so glad you mentioned that.
Yeah, go ahead, Tracy.
No, well, I'm just seeing the nods. I mean, that change in the carrying position of the arm during these episodes is something so many parents talk about. And Melanie, you could talk about it too.
Yeah, we had that last night. We took Chelsea for a walk, or the night before. I think I said, "Hey, Daisy, if you're watching, here's Chelsea." But so yeah, I mean, we can kind of see that coming. That's one thing for Chelsea too. She'll pull the left arm and just doesn't move it. I mean, you could put a bowl in front of her, and instead of holding that bowl and eating with her ice cream, she will use the spoon, but she won't move this left arm.
Okay, so we have time for just one more question, and we got through just about all of them, so this is great. And I think this question really also speaks to how amazing all of your presentations were, and really being able to share these experiences with other families. So someone wrote in basically saying that they have experienced similar things, and they've felt so much relief just from listening to your stories and your experiences. And the question is kind of, where do you even start? Now that they know that you all have experiences, they're not alone, where would you recommend parents start?
Not sure what start means in that question. Encourage parents to reach out to other parents, because there's so much wisdom in the parent group. And the Facebook pages are a great place to reach out and ask for help. And of course, anybody who feels they're living this and wants to be connected is free to send their information to the foundation and ask for it to be relayed to us. We'd be happy to connect. But I think the answer, if the question is, where do you start to help your kid? It's so different for each one that that's a much longer discussion. What would others say?
Can I just add something? Something that I think is really important is to advocate and do not give up. And when I say that, I mean, I'm a psychiatric nurse again, and I've had people tell me that in the beginning, Chelsea was like this because of her developmental delay. There was nothing else. And I knew in my gut, and I knew from other people that that was not right. So our psychiatrist, in his gut, he's also felt that something wasn't right with Chelsea. And he's a godsend to us, truly, because he now also has a couple other PMS kids, but he really pushed for us. But if you cannot find not just a practitioner, but other people who are not, I mean, we had family who wasn't supportive. I think you just need to trust your gut. And as Tazy said, like, the echo group wasn't there. I mean, you know, I just got a diagnosis, but I just think you really have to just keep going. It's hard, but it's harder to not have help and an answer.
Great. Thank you all so much. Tracy, do you have one last thing?
I was going to say, just agreeing with her that just make sure, and then just finding, when I talk to my doctor, saying we're in this group, we're finding out that this is something that several of our kids have experienced. And then sometimes, and starting off with that, will get the doctor's attention, because most of our doctors don't have more than just our kids with Phelan-McDermid syndrome. And so it makes them kind of tune in.
I just
Great, thank you. So I will turn this.
Thank you all. And just so much, you know, Tracy and Sheri and Melanie, thank you so much.
Thank you, Tazy.
Thank you.
Thank you.
Yeah. Thank you. Grateful.
Thank you, everyone. Can I just have a few closing remarks? Daisy, Tracy, Sheri, Melanie, Jackie, thank you so much. And I think your advice is amazing. You know, what I kept thinking of as I listened to you was our stories are our strength, and we need to keep telling them, and we need to keep telling them to each other, and we need to keep telling them to whoever we need to you know, get our collective voices to make life better for our kids. So thank you so much. all of you. I do want to ask our audience to make sure that you fill out the session evaluation. It is on your app, and if you look under the agenda, you can find this session, and then within the description there's a link, and you can send your feedback, and we really appreciate you taking the time to do that. We do have another session coming up next week, and that's August 12th. And just make a little note that we're doing the live session at 11 o'clock next time, and doing the encore presentation in the evening. One more shout out. Today is August 5th, August 9th. You'll be able to get your halfway to St. Patrick's Day feeling lucky garb if you'd like to if you'd like to do that. So that's only available until August 23rd. So I wanted to let you know. And then I just really, this thank you isn't enough to our panel. And I'm so glad that everyone could join us, and your work is amazing and so helpful and so inspiring for our whole community. So thank you. And thank you everyone for joining us. Good night, and be well. Thank you.